Hello, my name is Fenelon, and this is Advanced Assessment for the Family Nurse Practitioner Program at Columbus State University, Spring 2015 semester. Today I will be conducting a complete head-to-toe assessment as my project. Okay, before you complete your head-to-toe assessment, it is always important to introduce yourself to the patient so that any type of anxiety they have can be lessened. It's important to share information about what you will be doing so the patient can be aware what's happening at all times. Hello, Mr. Marshall.
Hello.
Mr. M, my name is Fenelon, and I'm a family nurse practitioner student. And today I am going to complete a head-to-toe assessment of you today, okay?
Okay.
Okay. Doing this assessment, I will be palpating, which I will be touching certain parts of your body. I will be tapping, which is percussing, and I will also be listening to various areas in your body. Is that okay?
Yes, ma'am.
Also, including with our assessment, you will be making certain movements so I can test your musculoskeletal system. So you will be moving from a sitting position to a standing position as needed, okay?
Okay.
All right. So I took the liberty before the camera started going to going over his vital signs. You always want to start a head-to-toe assessment reviewing the vital signs. And the vital signs for Mr. Marshall was the blood pressure on the left arm was 118/78. The right arm was 122/76. The patient is 6 feet tall, 183 pounds, which gives him a BMI of 24.8, which according to the CDC is of normal weight. The respiratory was 16, respiratory rate. The temperature was 97.6, and the heart rate was 62. Okay, Glasgow Coma scale was 15. His eyes open spontaneously. He is able to follow command, and his gait is steady and strong and well balanced. And so we're going to do an overall assessment of our patient. Before we get started, the first thing you start in any assessment is by washing your hands. Or if you can use hand sanitizer if your hands are not visibly soiled. So I'm going to go do that right now and use some hand sanitizer and clean my hands. And make sure to get in between the fingers. Okay, so we are going to start with the general appearance of the patient. The patient appears well nourished, well developed for his height. His neck and head appears to be of normal size. The neck is able to hold the head erect and strong. The patient does not appear to be in any acute distress at the moment. So we are going to start with the head area, the facial area, and the neck area. So we're going to start with inspection of the head. Inspection of the head, like I said, the head is of normal size for the rest of the body. It's not enlarged. We are going to inspect the scalp, and what we're inspecting the scalp for any nits or excessive dryness or lesions, excessive oiliness. Now we are going to palpate the scalp, and I'm going to tell my patient, Mr. M, if at any time you feel any type of tenderness or pain, please let me know, okay?
Okay.
All right, so then we're going to palpate the head. We're going to make sure we palpate all the area of the neck, of the head and the skull. No nodules were noted, no lesions are noted. The patient did not report any tenderness. And so now we are going to continue with palpation of the neck. The neck should be soft, supple, no enlarged areas. Okay, we're going to test the range of motion of the neck. Go ahead and turn your neck sideways. Put your head down. Up. Okay, this was the range of motion of the neck is within normal limits. That actually, so now we're going to continue assessing the facial features. We are going to inspect that the nose is central to the face. that the eyebrow hairs are evenly distributed bilaterally, that the eyes are symmetrical, and that the ears also are symmetrical. Now, continuing, we are going to go ahead and assess the patient's the patient's nose, neck, and lymph nodes. Okay. So I'm going to go ahead and use to assess the nose. We're gonna put our tip and have the patient tilt his head slightly back so that you can be able to visualize what's going on inside the nair. And what you're looking for is any exudate, any inflammation, any discharge. And in this case, both nairs appears free of discharge, free of inflammation, so that's a normal finding. Now we are going to test, we are going to palpate the nair, the nose for tenderness. Okay, and now we are going to test for patency. We're going to ask the patient to occlude one nair and breathe through the other one, and occlude the other one. Okay, that sounds, the nose is patent. He doesn't sound congested at all. And so we are going to continue by assessing the ear. When assessing the ear, you want to, like I said, inspect that they are symmetrical. And then you're going to palpate for temperature, color. We're going to palpate the pinnae, the tragus, the lobus. And then we're going to go ahead while we're doing our palpation of the ear and go ahead and palpate the lymph nodes. We're going to start with the preauricular lymph nodes and just palpate the preauricular lymph nodes, the posterior auricular lymph nodes, the occipital lymph node, the submental lymph node, the submandibular, and the tonsillar. We're going to continue moving down, palpating the superficial cervical, the deep cervical chain, the posterior cervical, and of course the supraclavicular lymph nodes. Now all the lymph nodes should be small, soft, and movable, which they were. There was no enlargement of the lymph nodes noted. So that is our assessment of the neck and lymph nodes. We are going to continue now with assessment of the patient's eyes. We are going to assess cranial nerve 3, 4, and 6. Cranial nerve 3 is the oculomotor nerve, which tests for pupillary reflex. The trochlear nerve, which is cranial nerve 4, which asks for eye movement, and cranial nerve 6, which is the abducens, which also tests for extrinsic eye muscle movement. So what I'm going to do is ask the patient to look straight at me with the light, and we are going to test that. We are going to test the 6 cardinal fields of gaze, which is going to happen on. We're going to instruct the patient to keep your head still and just move your eyes for me, okay? The eyes are moving purposefully and smoothly. No nystagmus noted, no strabismus noted. Okay, all right, now I'm going to ask the patient to look at a point behind me and then look at the light. All right, the eyes were able to converge symmetrically at the same time. So that is a normal finding for the cranial nerve 3, 4, and 6. Continuing with our neurological system evaluations, at this point we are going to test the cranial nerve 5, which is the trigeminal nerve, and which also controls tongue movement. We are going to ask the patient to stick his tongue on the side of his cheek against my fingers on the other way, and then move his mandible, move his jaw from side to side, which is a normal finding. Now we are moving to cranial nerve number 7, which is the facial nerve, which also includes taste. At the same time, we are going to also test cranial nerve 1, which is the olfactory nerve for smell. So I'm going to go ahead and have my patient turn, and I'm going to have him close his eyes. And then what I'm going to do is have him occlude one nair, and smell and tell me what he smells.
Coffee.
Okay. He was able to correctly identify the smell of coffee with one nail occluded. And now we're going to test the other nail with his eyes closed. I'm going to ask him to tell me what he smells.
I smell vanilla.
Okay. He was able to correctly identify the smell of vanilla. That concludes our cranial nerve number 1, which is the olfactory nerve for smell. And now we are going to assess cranial nerve cranial nerve 7, which is the facial nerve, which also includes taste. So I've got 2 things here. The patient's gonna close his eyes, and I'm gonna have him stick out his tongue.
Salt. Sugar.
Okay, he was able to correctly identify the different tastes. So that cranial nerve is intact. And so now I'm going to assess the vagus nerve by giving him something to swallow. The vagus nerve, which is cranial nerve 10. Okay. And while he's swallowing, I went ahead and palpated the thyroid, which was mobile. I did not notice any enlargement of the thyroid gland, which is a normal finding. Okay, so cranial nerve 11 is the accessory muscles, which test the sternocleidomastoid muscles and also the trapezoid muscles. I'm going to go ahead and ask the patient to shrug his shoulders for me against resistance. He's able to do that. And now we're going to go back to cranial nerve 7, which is our facial nerve. We're going to have the patient smile widely. Smile. Close your eyes. Open your eyes. Frown. Okay. All right. Now we're going to go ahead. We'll continue with our new assessment with light sensation. The patient's going to close his eyes, and he's going to tell me when he feels the sensation by saying now.
Now. Now. Now. Now. Now. Now. Now.
Okay. Light sensation is intact, and so what we are going to do now is test look into his ears. We've already inspected the outer ear. We've palpated the outer ear. And so now we are going to look into the middle ear canal. What you want to do in an adult patient is to pull the pinna up and back. And what you're looking for, a moderate amount of cerumen is not abnormal. That is within normal limits. It's not too much, and I am able to see the tympanic membrane, which is a pearly gray. It's not bulging. It doesn't appear to be ruptured. This is consistent because the patient have not been complaining of any ear pain. And so you do the same thing you do on the other side. You're gonna do on the right side. So we're gonna assess the right ear the same way we assess the left ear. Gonna go all the way around. We're gonna notice the light reflex of the tympanic membrane. It is within normal limits. There's not diminished light reflex, which would indicate fluid behind the ear. There's no redness or drainage, which would indicate an acute otitis media going on. So that is our assessment of the ear. And now we are going to assess the mouth. Okay. We're going to have the patient open his mouth and say, all right, we are going to have the patient open his mouth and say, ah. Ah. We are noticing, okay, gag reflex was intact, but we are noticing, we're going to take our light and shine it into it. The uvula is midline, the tonsils are not enlarged, no exudate. Okay. The hard palate and soft palate is within normal limits, no lesions, no cracks. The gum lines, we're going to assess the patient's teeth. All right, the amount of teeth happens to, looks to be within normal limits for an adult. I'm going to assess the gums. They are pink, no lesions noted, no cracks, no evidence of any mouth ulcers, no infections. It is important to encourage patients to maintain regular teeth maintenance, such as cleanings on a regular basis. So, Mr. M, when was your last cleaning?
Last month. Okay.
And how often do you get your teeth looked at by the dentist?
Twice a year.
Twice a year, which is what is recommended, because teeth health does have a correlation with cardiovascular health. So you always want to encourage that area. And so we're still in the head, and now what we are going to do is, we did the 6 cardinal fields of gaze, and now we are going to assess pupillary constriction. So we're going to have the patient look straight ahead and shine the light. Okay, and you should see that the pupils constrict and the other eye constrict bilaterally symmetrically. So that is known as perla, pupils equal round, reactive to light and accommodation. All right, so now we are going to go ahead and continue. We've tested the nerve, the lymph nodes, the head, the ear, the eyes. We're gonna finish further assessment of the eyes, because you have to notice the conjunctiva. Have the patient look up, and then the upper conjunctiva. Have the patient look down. Now the conjunctiva is nice and pink and moist. Now you are going to palpate the eyelids. Make sure, notice that the eyelids cover the eyeballs completely. We're going to palpate the eyelids, palpate the frontal sinuses, and also palpate the maxillary sinuses. Do you feel any tenderness or pain, Mr. M?
No, ma'am.
Okay, so palpation of the sinuses was within normal limits, no pain, no nodules noted, and so on and so forth. Now, palpation of the eyeballs revealed that it's nice and firm. If it wasn't very firm, if it was soft, that might indicate dehydration, and a conjunctiva that is not pink, that is pale, might indicate anemia. And so you also want to be aware of what these assessments might mean when you test them. Okay, so then we've completed the assessment of our cranial nerves. We've done the 3, 4, and 6. We've assessed the gag reflex, the cranial nerve number 5, the hypoglossal. So now we are going to assess cranial nerve 8, which tests for hearing. Okay, so this is the vestibular cochlear nerve. I'm going to perform the whisper test on my patient. I'm going to have him close one ear, and I'm going to, about 2 feet away from him, I'm going to whisper a statement, and he's going to tell me what it was.
1, 2, 3.
Okay, now cover the other ear for me, Mr. M.
ABC.
Okay. He was able, there doesn't seem to be any evidence of diminished hearing in his ear. He is able to see, to hear correctly. In the clinical setting, you might use, if you had a tuning fork, the practitioner may use a tuning fork to assess bone and air conduction further. Okay. All right. So that was our cranial nerve 8. So now, keeping in line with our head-to-toe assessment, we are going to evaluate the cardiovascular and peripheral vascular system. Okay, we are going to palpate the temporal artery first. And it's light palpation of the temporal artery. We are going to palpate the carotid artery one at a time, very lightly, because you do not want to do it both at the same time, which may occlude airflow to the brain. Okay, we are going to assess the brachial artery, the brachial pulse, the radial pulse, and of course what we're doing to one, we're doing to another. Okay, that is within normal limits. And now we're going to go down for our peripheral vascular assessment. We're going to assess the pulses, the pedal pulses, the dorsalis pedis, the posterior tibial pulse, and the popliteal pulse. And then we will continue with the other leg. Again, the dorsalis pedis, the posterior tibial, and the popliteal pulse. While we're down here, we are going to note the temperature of the extremities. They should not be overly cool, which may indicate cardiac insufficiency. We are going to test for capillary refill, which is brisk. We're going to note the distribution of hair in the lower extremities, which is symmetrical and even bilaterally. So continuing with our cardiovascular assessment, now we are going to assess the interior thorax. And what I'm going to do is I'm going to assess the interior thorax, and I'm going to move to the back of the patient and assess the posterior thorax. So I will be assessing the cardiac and lung sounds on the interior thorax. Okay, so the first thing we're going to do is inspection. We're going to notice that there are no cyanosis noted, that the patient is not using any accessory muscles, that there is no nasal flaring, so he does not appear to be in any acute distress. And we are going to palpate the cardiac borders. And of course, you should be able to palpate the apical pulse, the apex. Okay, and so what I'm going to do now, we are going to test for respiratory expansion of the interior thorax. You're going to put your hands along the costal margins, and I'm going to have my patient to breathe for me deeply. And notice how my hands move symmetrically, bilaterally, which is a normal finding when assessing for the respiratory expansion of the interior thorax. So now we have palpated. We are going to palpate the lung fields for tactile parameters. I want you to say 99.
99. 99. 99. 99.
Okay. Tactile parameters heard over all lung fields. And so now what we are going to do is percuss the lung area. And at the same time, we're palpating we're percussing the cardiac borders and the lung fields. And of course, resonance is heard above the lung area. All right, now we are going to auscultate for our interior cardiovascular assessment and peripheral assessment. We're going to auscultate the temporal artery, the carotid artery, and now we're going to auscultate for cardiac sounds. And you wanna listen for a full minute. Okay, auscultating the heart, I started at the right second intercostal space, and then I moved left to the sternal border, and I auscultated down from the 2nd to the 5th intercostal space and also to the apex. So now I'm going to do the same thing with the bell of my stethoscope, and S1 and S2 was heard, which were normal heart sounds. Now I'm going to use the bell of my stethoscope to assess for any bruit, temporal artery bruit, carotid bruit. I'm also going to assess the thyroid for any bruit, and I'm also going to assess the chest, the cardiac for any extra heart sounds such as an S3 or an S4. Gonna auscultate the carotid for carotid bruit. Go ahead and hold deep breath and hold your breath for me. Okay, breathe normally. No bruit is heard over the temporal artery or the carotid artery, and no bruit over the thyroid. And now we'll auscultate the heart for any extra heart sounds. Moving along the left sternal border, the 2nd to the 5th intercostal space, just like I did with the diaphragm of my stethoscope, and also the apex. Okay, no extra heart sounds was heard with the bell of my stethoscope. And now what I'm going to do is I'm going to assess the apical pulse and also the carotid pulse, and they should correlate. Okay, the pulses at the apex and the carotid correlated, so that concludes the anterior thoracic portion of my assessment. And now I'm going to, I did respiratory expansion, and now I'm going to move to the back of my patient, and I'm going to assess the posterior thorax. And the first thing I'm going to do is palpate for tactile fremitus. Go ahead and say 99.
99, 99, 99, 99.
Okay, so tactile fremitus failed on all fields, so that is a normal finding. And now what I'm going to do is percuss the lung fields. And of course, resonance heard above the lung fields, no dullness noted. First I'm going to go and percuss. I've palpated all the lung fields. While I'm here, I will go ahead and percuss the kidneys with blunt percussion or fist percussion, and I'm going to ask the patient if that is causing any pain. And what I'm placing my hand over the costovertebral angle. Any pain and tenderness?
No, ma'am.
Okay. Percussion of the kidneys did not elicit any tenderness, which is a normal finding in this case. All right, now I'm going to listen, auscultate the lung fields. Deep breath in. Deep breath out. And you wanna listen for a complete respiratory cycle in all areas. Okay, bronchovesicular sounds was heard over the between the scapula and
Shoot.
Okay, hello again. Our video recording device stopped doing our posterior thorax examination. So we are going to continue where it stopped and finished our assessment. Like we did before, we palpated the posterior thorax along the lung fields for tactile firmities. Go ahead and say 99.
99.
99.
99. 99. 99.
And then we are going to percuss along the lung fields. I'm going to twirl my patient around so the camera can have a better view of where I am percussing along the lung fields. And vesicular sound is heard over the lung fields, and bronchiovesicular sound is heard over between the scapula. All right, we are going to continue now. We are going to do the diaphragmatic excursion measurements. I have a pencil and also a ruler that we are going to use to measure. And the way we do that is to have the patient exhale and hold his breath. Go ahead, sir, exhale and hold your breath. And between the scapula, we are going to start percussing until we hear dullness. And then we are going to mark that area. Okay, inhale and hold your breath. Okay, until we hear dullness. Okay, and then we're gonna do the same thing for that area. Go ahead, exhale and hold your breath between the scapula again until we get to the area of dullness. And then go ahead and inhale and hold your breath. And then we are going to continue with our percussion until we hear dullness again. And so we're gonna mark these two areas. We are going to take our measurements and measure, which is about 4 centimeters. Okay, it's about 4 centimeters bilaterally. So diaphragmatic excursion is symmetrical and bilateral. Go ahead and breathe normally for me, sir. Okay, now we are going to auscultate for the lung sounds. Take a deep breath in, deep breath out. Okay, lung sounds are clear. There are no wails or crackles noted, or no wheezes noted also. And so we are going to now turn our patient over and continue the assessment of the peripheral vascular system. The first thing we are going to do is assess his nails and assess the capillary refill, which is brisk. Okay, we're gonna assess the temperature of his arm, note the hair distribution of his upper extremity and also his lower extremity, which is in his legs. The hairs are evenly distributed. And now we are going to palpate for the brachial pulse, the radial pulse. And you're gonna wanna do that bilaterally. The same thing you do on one side, you are going to do on the other side. So I'm going to move over on the other side. Okay. And the pulses are present. They're not diminished. And so now we are going to test the pulses of the lower extremity. We are going to start noticing the temperature of also the lower extremity, the pedal pulses, the dorsalis pedis, and that's present. We're also going to palpate the pulses for the posterior tibial, and also the popliteal pulse. And now we are going to palpate the pulses on the right lower extremity also. We are going to do the dorsalis pedis, the posterior tibial, and the popliteal pulse. Okay, and all that was within normal limits. And now I'm going to have the patient hold on, and I'm going to take his ankles and actually assess the musculoskeletal assessment, just combining more than one assessment together. And I'm going to ask him to flex an extension. Okay, and I'm going to move it. Do you feel any pain or tenderness?
No, ma'am.
Okay, we are going to assess the other ankle. First, we are going to palpate and make sure there are no nodules. Okay, and the joint move freely without difficulty, without cracks. And so we're going to ask the patient to flex his ankle and extension. All right, and side to side. That seems to be within normal limits. Another thing we are going to do when assessing the neural system is called stereognosis. Stereognosis is the ability for the patient to identify an object without looking at it. So at that point, I'm going to ask the patient to close his eyes, and I'm going to put something in his hand, and he's going to tell me what it is.
It's a coin, a quarter.
Okay, so he correctly identified the quarter, and we are going to do that with
It's a pencil.
okay, he correctly identified that also. And now what we are going to assess for the patient at this point is graphesthesia. Graphesthesia is also a neural assessment where the patient keeps his eyes closed, and I am going to write in his hands the shape of something, and he's gonna tell me what it is.
The number 3.
The number 3, which is correct.
The number 4.
The number 4, which is also correct. So all of that, the new assessment was within normal limits so far, and we've already assessed the cranial nerves. And now at this time, we are going to help the patient to a standing position, and we are going to assess cranial nerve 2, which is the optic nerve. So I've already set my Snellen chart, and I've already measured a distance of 20 feet, where now the patient's going to walk, and he's going to conduct the test. Thank you very much. The lowest line that he can read.
D-E-F-P-O-T-E-C.
Okay, now close the other eye and read.
D-E-F-P-O-T-E-C.
Okay, and both eyes.
D-E-F-P-O-T-E-C.
Okay, the patient is reading at the 20/20 level. That means he's got normal vision. He does not wear any corrective lenses, meaning that he can read at 20 feet away, what most people can read at 20 feet away. Now we're going to ask the patient to walk back and sit, and I'm going to have him, I'm going to give him the near vision card and have him read at 16 inches away, the smallest card that he can, the smallest area he can read.
D-Z-E-C-L-P-T-O-F.
Okay. The other one?
D-Z-E-C-L-P-T-O-F.
Okay. So, near vision also is within normal limits, which is not an abnormal finding since my patient does not wear any corrective lenses. And now we are going to move into the musculoskeletal part of my assessment. We're going to assess the shoulders. First, we are going to palpate the spinal processes. Make sure there aren't any lumps, any nodules, any tenderness. We're going to have the patient bend over Pretend like he's touching his toes, and look for the curvature. There's no abnormal curvature of the spine. It's a regular C shape when he turns over, and of course you want to run your hands along and palpate. Again, no tenderness, no bulging. All right, go ahead and stand up. And so now what we're going to have my patient do is the shoulder. We're going to assess the patient's shoulder. We're going to start at the suprasternal notch and move our hands along the clavicle to the acromion process. We're just palpating the shoulders. And then we are going to move our hands medial to the AC joint. And then move it down to the coracoid process, and then the lesser tubercle, and then the greater tubercle, and of course the scapula. We're going to palpate all of that in the shoulder. We're going to do the same thing with the other side, the suprasternal notch. Move along the clavicle to the acromion process. And we are going to move again down to the AC joint. And then continue moving to the coracoid process, the lesser tubercle, the greater tubercle, and of course the scapula. And I'm going to have my patient rotate his shoulders forward, rotate backwards, move your head to the side, and just rotate your shoulders and rotate back. That's good. Now go ahead and put your hand on your hips and just go from side to side. Front, the back. Any pain doing that, sir?
No, ma'am.
Okay. That part of the musculoskeletal system is within normal limits. He was able to bend over, move side to side. And so we are going to continue. Now while he's standing up, we did the whisper test. So now we're going to do the second portion of the cranial nerve 8, which is equilibrium test. What we're going to do is have the patient stand with his feet together, with his eyes open, and you're gonna hands at the sides. Okay, now we're gonna have him close his eyes, and you want to be close to your patient in case this test he loses balance, providing protection and keeping your patient from getting injured. And you're gonna have him see whether or not he sways. Mild swaying is a normal finding. So and you're gonna keep the patient here for about 20 seconds and notice. Okay, this will be considered a negative Weinberg test. Go ahead and open your eyes for me. And so to continue assessing balance, we're going to have the patient walk knee to toe in a straight line. Okay. Okay, he's going to turn back around and walk knee to toe. Okay. And now that was within normal limits. And now we are going to have the patient have a seat on the couch for me. And we are continuing with our musculoskeletal system. We are going to assess the joints of the wrist. We're going to palpate the joint of the wrist and make sure that we don't feel any nodules that may possibly be consistent with rheumatoid arthritis, that there isn't any tenderness and no pain elicited. We are going to, of course, notice the shapes of the nails, palpate the joints of the fingers. Okay, and have the patient, okay, now extend. Okay, the movement of the wrists are within normal limits, and now we are going to assess the movement of the elbows. Go ahead and push back. And now I'm going to assess the strength of the muscles. Push against my hand, keep me from pulling you. And now I'm going to ask him to grab my fingers and squeeze, which assess muscle strength, which is within normal limits. And now we're going to go ahead and have him what we're gonna do at this point is, one thing we haven't done yet is the deep tendon reflexes. We're gonna go ahead and have that done right now. So we're going to use the patellar. Okay, that was within normal limits, and we're going to do the posterior tibial. Okay. All right, now we're gonna do the biceps, the triceps. Okay. Okay. And the brachioradialis. Brachioradialis again. Okay. And of course the triceps. Okay. The deep tendon reflexes were within normal limits, and so now we're going to have our patient lie down for me. Continuing with the musculoskeletal system, we're going to have him bring his hips up, bring his knees up. We are testing the strength, and extend your legs. Keep me from pushing it down, and keep. Okay, we're going to check the other one. Okay, all right. Move your hips, just flex your knees for me. Lateral. Now keep me from pushing it, keep me from pulling it. The other one. So now we are just assessing the range of motion and the strength of the hip muscles, which is all within normal limits. And so now we are going to move on to, now that our patient is laying down, we are going to move on to the examination of the breast. And okay. On a patient in the clinical setting, you would be assessing that on the skin, but for patient privacy and modesty, he's going to keep the shirt on. But you're going to start. My method is the vertical method, the vertical strip. I'm going to start at the mid-axillary, palpate the axillary lymph nodes, and just move down and move up. Move over and down, over the breast tissue. Now, breast health is just as important for males as it is for females, because men also can get breast cancer. And so you would teach your patient to do a self-breast exam also every month. So now with the other hand, I'm going to have the patient repeat what I've just done so that I know that he knows how to do it. Down. Okay, now we're going to do the same on the other side. Okay. And the patient has already demonstrated that he knows how to do a self-breast exam. So now we are going to continue with assessment of the abdomen. The first thing you're going to do is inspection. Make sure it's not distended, which might be a sign of ascites. Doing this procedure, this assessment, you wanna auscultate before you start palpating and percussing, because you may initiate hyperactive bowel signs that may not be there. So we're going to go ahead and listen with our bell of our stethoscope on all 4 quadrants. The right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. Now bowel sounds are active on all 4 quadrants, and now we're going to use the bell of our stethoscope and assess the aortic area, the iliac, and the femoral arteries, and the renal arteries. And what we are assessing for is any vascular sounds, the aortic area. We are assessing for any femoral iliac, femoral, or vascular sounds such as bruit or splenic and hepatic friction rubs. And now I'm going to say the iliac artery. And now I'm going to go ahead and assess the femoral artery, which would be right up. And now I will continue my assessment with palpation. We're going to start with light palpation. And my patient is aware that I was going to palpate. So you start palpating the same area as your auscultation, the same pattern. You palpate the right lower quadrant for tenderness, any bulging, any nodules, any pain. Now over the colon might be a little tender. That is not necessarily an abnormal finding. Prior to our assessment, I informed the patient to empty out his bladder, which he did. Okay. All right, now that we've done the light palpation, we're going to do deep palpation, and we are going to test to see the borders of the liver. Now the spleen should not be palpable. If it is palpable, that is an abnormal process that may indicate an infection such as mononucleosis, which may lead to enlargement of the spleen. So okay, so take a deep breath for me. Sometime when they take a deep breath, you can actually feel the liver, the edges of the liver. Exhale. Deep palpation. Like I said, the spleen should not be palpable. Any pain?
No, ma'am.
Okay, the palpation of the abdomen did not elicit any tenderness or pain upon palpation, which is a normal finding. Bowel sounds were active and all present sounds. I did not hear any vascular sounds such as splenic or hepatic friction rub, which is a normal finding. And so now I'm going to go ahead and percuss. At the same way that I auscultated. And so I heard tympany over the abdominal area, which is a normal finding. And so I'm going to have my patient stand up, sit up. That concludes our abdominal assessment. To recap real quick, I'm going to go over what we've done today. We assessed the eyes. We assessed the 6 cardinal fields of gaze. We assessed pupillary reaction, which was perla, which was within normal limits. The Glasgow Coma scale was a 15, which is normal limits. My patient's awake and alert to person, time, and place. He is well groomed. He's well developed. He had no trouble with his balance. He was able to hear. Cranial nerve 8 was intact. Cranial nerve 1, 2, 3, 4, and 5 were intact. 6 was also intact. The facial nerves was intact. We assessed the vagus nerve, cranial nerve 10, which was the swallowing. The accessory muscles with him moving his shoulders was within normal limits. The hypoglossal, which was cranial 12, which is movement of the tongue, was within normal limits. Deep tendon reflexes were all within normal limits. Romberg test was negative, so that was normal. And now what we're going to do is assess his sense of sharp and dull, which we haven't done. And so I'm going to have the patient close his eyes and tell me where he feels it and what sensation he feels.
Sharp on my left hand. Dull on my left arm. Sharp on my right arm. Dull on my left hand. Dull on my left leg. Sharp on my right leg. Dull on my left foot. Sharp on my right foot.
Okay. Well, his sharp and dull sensation is within normal limits. That is also a neurological assessment. We assessed his ears, we palpated his thorax, his respiratory, cardiac, peripheral, cardiovascular, and respiratory system was all within normal limits. The jugular vein was not distended. We assessed the lymph nodes and the supraventricular, supracervical, and so on along his neck. His neck was supple. We assessed all the artery, the temporal, the radial, brachial, and dorsalis pedis, posterior tibial, and popliteal. All those pulses were present and within normal limits. They were not. The skin and the nails were within normal limits. The temperature was warm and even throughout. There's no excessive coolness, which would have indicated cardiac insufficiency. I believe this concludes our head to toe assessment. We also assessed his sinuses, his ears, his nose, his mouth, and so now I'm gonna go ahead and indicate to our patient that our head to toe assessment is now complete. Mr. M, thank you for your time and thank you for letting me take care of you. I am done with your head to toe assessment, and I would like to let you know I did not find anything abnormal, so everything was within normal limits. So thank you very much for your time. And when we finish, the same way we start by washing our hands after every patient contact, you also want to wash your hands also. And at this point, I'm also going to be using the hand sanitizer at the end of my assessment. Thank you again. That concludes my head to toe physical assessment. Thank you for watching. And I'm Snavely Fenelon.
Okay, go.
Okay, one correction that I would like to make with the previous recording, as my patient was walking from heel to toe, I said knee to toe, and so I would like to make that correction. And at this time, I would like, okay, thank you.